If you're interested in starting a residential care facility or group home or assisted living facility, or maybe commercial, or if you currently operate any one of these businesses and you're worried about being able to protect your income and revenue potential, and you want to maybe learn how to diversify those income streams and license with Medicare and Medicaid, this video is for you. We're going to talk about home health agencies and home care agencies and how they can help you get different lines of business so that way you can thrive in this ever-changing, ever-turbulent healthcare business environment. Stay tuned, lock in.
I am faith-based, and I do thank God for opening up my heart to look into home health, because once you go home health, you don't go back. So the opportunities keep increasing, and they're limitless based on which way or how you want to grow that line of business. So really large publicly traded home health agencies got some much wider experience as executive director. Agencies are regulated by states, and then there's also federal regulation depending on what level you want to run a home care agency. Home health agency or home care agency, these two names get used interchangeably, and I'll briefly talk about the difference. And then there are many advantages for an ALF owner or a group home owner to open a home care or a home health line of business in alignment with what they're doing. They are individual providers in the community. They're not really licensed. The state of Florida has exemptions for people that are not, or groups that are not operating as an agency yet, or they're working their way through. So those exemptions are ways that individuals that are starting from scratch, that really, they might have an LPN, they might be an RN as an individual and want to really get their feet wet. The unique thing about Medicare enrollment is usually a capitalization calculation that is usually either based on the anticipated volume of care that you're looking to provide.
So Nia, you are a nurse by profession for how long?
13 years.
13 years, and you decided to leave the bedside and open up your own home health care agency because?
Because I wanted to reach more providers, and it didn't go from bedside to what I'm doing actually. But I also felt that there's a lot more room for consultants and people that can teach providers versus, say, going a route of, say, opening my own home care agency.
Okay. Yeah. And there's a lot of steps that go to opening a home care agency. As you very well know, as a consultant, there are a lot of barriers to entry.
Yeah.
Can you talk about some of those barriers and the challenges that some of the providers that you work with face?
Yeah. So one barrier to entry that gets a lot of people is capital. And to get a license, there's usually some financial stipulations that that anybody that wants to be a provider has to be able to demonstrate fiscal ability to capitalize into those businesses. And so financial preparation has to happen for anybody who's a prospective, home care owner or prospective provider that wants to get into the business of healthcare or start an agency to be able to prepare for, so that the license fees can be covered, consulting fees can be covered. With the consulting fee, and then basic operational costs can be covered. For instance, getting a location that you're going to be able to work from, the first few staff that can help you get started. Those are all costs with that. The other barrier is, I call it informational overload. There's a lot of information online now, but there's usually some additional simple, not simple, but specific, unique things that different states have as far as requirements. With information overload, people that are trying to start these companies or these agencies or become healthcare providers in an organizational and entity setting don't have the specifics that they need. So that's where it's important to get a consultant or somebody that can walk you through and how to navigate all these requirements in an organized fashion, simplified, without putting a lot of stress on you while you're focusing on building the operational part for the business.
Yeah, for sure. That definitely makes sense. I know that when it comes to like policies and procedures for your business, a lot of people will potentially work with a consultant who maybe doesn't have home health care experience or is out of state and they don't know the nuances of the regulations for the location that this provider is going to be operating.
Yeah, and that you hit on a very big point there, that agencies are regulated by states, and then there's also federal regulation depending on what level you want to run a home care agency. And so different states have certain autonomies or different ways that they've rewritten their laws to be able to fit the demographics or the people that are receiving healthcare services. And so consultants typically get educated throughout the process to be able to help you navigate those different state laws and what the simple, in this state we do this extra step, or to ensure compliance and quality. Again, those are some of the challenges that the information people get online can be very generalized. It can be boom, 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 but it doesn't step by step, but it doesn't specifically address what ACA in the state of Florida looks for. Or, the DIA, Department of Inspection, Licensing and Appeals, let's say in the state of Iowa, what they're looking for. So basically, those are the challenges, is to get organized with the financial piece, get over that, get the right information, because with informational overload as well, it can take you a long time to comb through all that information to get what you need. And so without some kind of a support or a guide or a consultant that's teaching you what to do or how to do it, it can take you a very long time to get that agency up and running. And so those are typically some of the challenges, is to know how, and then all the requirements that are needed and to get the right guidance.
So for those who don't know, what is a home health care agency? Why might someone who is an existing operator of a group home or an assisted living facility, why might they want to start a home health care agency? What benefit could providing services through their home health care agency serve their business?
That's a great question. So a home health agency or home care agency, these two names get used interchangeably, and I'll briefly talk about the difference and then add on the importance of having those services in an ALF or a group home setting. A home care agency is a service that is provided by typically staff that are home health aides or certified nurse aides that don't require professional licensure to help in the home with basic life functioning activities. We call them activities of daily living. So your cooking, your simple cleaning, your bathing, your homemaking, companionship. Those are all services that a home health aide or a certified nurse aide can provide. It does not require the skills of a professional, say registered nurse. When you move into the home health side of things, typically there's advanced clinicians or clinicians that have licenses. So we're talking about your registered nurses, your LPNs or LVNs, your therapists, your medical social workers. Home health is a little bit a step ahead, and When you hear home health agency that provides these skilled services, these licensed professionals that go into clients or patients' homes, home health agencies are usually accredited, which is an additional step on top of the licensure piece that a non-skilled home care agency is typically just licensed. So on top of being licensed, a skilled home health agency has to go through an accreditation process, which is basically taking on more regulatory burden, more oversight, but also you get the opportunity to bill Medicare or private insurances that will credential you in. There are many advantages for an ALF owner or a group home owner to open a home care or a home health line of business in alignment with what they're doing. One is the staffing piece. There is a known staffing shortage across the U.S.
Yeah.
And when you already have your established ALF or group home.
That's okay. Yeah, that's okay. So you were saying when you have your established group home or ALF and you're considering starting a home care or home health agency?
You already have a set of staff that you can utilize that when you bring in that home health line of business, you have some sort of staffing, a competitive advantage with staffing that is already established there for you. Because one of the challenges with home care and home health agencies is staffing. It is a very tricky balance there along with a shortage and just high turnover in general. The other advantage is just marketability. You are adding additional services to your clients. And so you can position yourself as an ALF owner or group home owner better with networks or healthcare networks, or if you're looking to work with physician groups, if you're looking to get into Medicare Advantage or private insurances, or even Medicare and Medicaid, working and doing business with CMS. The other advantage of having a home health service is just it's an extra line of business, right? So it is an opportunity for you as a group home or an ALF owner to have additional revenue source. Because being a different line of business, you can bill those services separately. There are ways that you're supposed to handle those billing and make sure that you meet the conditions of billing for any insurance that you're going to be collaborating with, but it creates that line of business for you. So that's on top of what you're doing. And the other advantage, I know I mentioned marketability, but whenever you add on another line of business, you're taking on more regulatory requirements. Mm-hmm. And whenever you decide as a provider to take on more responsibility and quality expectations behind you, you tend to open up a lot more doors. For instance, with a home health agency, a lot of Medicare Advantage insurances, you can get into Medicare. You open up those business opportunities for you for growth, which we love what we do as healthcare providers, as nurses. But when you get to the business side of things, you're also looking to grow. You're looking to get to partnerships that are strategic, whether it's insurance companies, whether it's CMS, Centers for Medicare and Medicaid, whether it's private groups, private paying individuals. So having wider scope as far as lines of business, including home care, opens up all those doors for you, especially with that accreditation piece. Yeah. It just gives you that competitive advantage because Medicare accreditation or CMS accreditation, it does involve quite a bit of quality expectations or measures that the providers have to demonstrate, including that financial piece that we talked about before they can get those kind of endorsements.
Yeah, that's a big deal. I feel like diversifying your revenue sources, it only makes sense. And when you consider here in the state of Florida, there are a considerable number of group homes that are vacant, assisted living facilities that are under occupied. And when you just rely on a single payer source, it limits the ability for you to, build your business.
Yeah. And creating those service lines, it allows you also to leverage the case managers and we talked about hospital networks, physician groups that are always looking for placements and what other additional services. So in that, distinguishing yourself and giving yourself a competitive advantage, it is nice or may make it a little bit easier for the case managers or the social workers that are placing, knowing that you have that additional service. Because if you have home care or home health and you're an ALF, if a patient or a client needs that service that's already with you, that is one less provider that those discharge planners and those case managers have to go look for those people to bring in. And so you're offsetting that burden to those care coordinating professionals. And they really love that. They need that.
And that's something I didn't think about. I mean, when we consider the coordinators that we have to work with and just the sheer volume of clients that they have to serve. And
how fast they have to turn them around. You understand, being in the hospital, those 3-day stays or, short stays, major kudos to them. We love our coordinators.
They're definitely not supported in the way that we would like to see them in the ideal world. And so for us to be able to take a load off of their shoulders and, be the route that can provide the additional services for the clients, that definitely creates like a win-win solution. Because one thing we've come to learn is that, you have to be the doctor, you have to be the nurse, you have to be the parent, you have to be the legal guardian, you have to be the anything and everything for the clients that you serve.
It all around is a win-win, I think, for providers that already have like a brick and mortar setting, a building. And also, once you are licensed and are accredited, you can also serve patients or clients in the community. So there's your dual ability. With an ALF or group home, your clientele can be confined into those environments, right? But when you have this home health agency and you're getting licensed, you get licensed for a territory, you get licensed for a county, you get licensed for multiple counties in Florida. When you get accredited across those counties as well. So as a business owner or a provider, you can establish services for your group home ALF clients, but you can also set up an external community-based service where you're servicing members, not just in this home, but you can go to the community. So in home health, you have those institutional referrals or patients that are coming in for an acute setting, whether it's a hospital, an LTAC, or a rehab center, that are going straight home to their private residence. As a home health agency, you can set up your business to be able to serve them. And then you have your own, and then you have other ALFs that you can partner with and be able to send your people. So the opportunities keep increasing and they're limitless based on which way or how you want to grow.
So we got accredited with CHAP, and there are other accreditation bodies, right? For someone who is considering starting a home care or a home health agency, do you still have to do the same accreditation process? Is it different? And like, just depending on the route, if you wanted to have specialized care versus non-specialized care, could you lay out a framework for how someone will go about having the idea and then, getting their final approval to be able to provide services in the community?
Yeah. So that's a little bit of a loaded question.
Okay.
I'm also CHAP certified consultant, by the way.
Okay.
And so I tend to work with that accrediting organization. But basically, if you're going to do personalized services that are not requiring the skills of professional, like your non-skilled home health aide, CNA disciplines that are providing assistance with ADLs and individual IADLs in the home, the route is to get licensed so you can have a competitive advantage. There are individual providers in the community that are not really licensed. The state of Florida has exemptions for people that are not, or groups that are not operating as an agency yet, or they're working their way through. So those exemptions are ways that individuals that are starting from scratch, that really, hey, and they might have an LPN, there might be an RN as an individual and want to really get their feet wet and understand how going from one client to another is. You can apply for those exemptions and start small. And then once you start picking up momentum or you're getting more clients and you want to get to an agency route or an entity, an organization, then you can go ahead and apply for that license for a home care non-skilled agency, right? Based on the service that you're providing. At Home Health Edge Consulting Group, which is my baby and what we do, we have simplified the process to a 4-step process. So you're in phase 1 and phase 2 to get the licensure. And then if you want to become accredited, which is where CHAP and ACHC and the Joint Commission, which are accrediting organizations, come in, we put you through phase 3 and 4. Phase 3 is the Medicare enrollment, which you have to enroll with CMS. And then phase 4 is the accreditation. Phase 1, which I talked about but didn't specify, is basically getting you ready for the license enrollment with your state.
Okay.
So for the state of Florida, phase 1 is to enroll with ACA. That involves an application process. It also involves the state coming out to do a basic assessment of your office and your policy and procedures and making sure that you have those in place. And then phase 2 is that survey part that I just talked about. Somebody coming out from ACA or as a representative of ACA. CHAP and the accrediting organizations are contracted to take on those 2 steps if you are going the accreditation route. They will be the people, the group that comes out to survey the licensure piece as well as the accreditation piece. If you're basically non-skilled personal care services, non-medical, those are all terms of this home care agency setup, and you want to end there at the license level, that's the process. But you want to grow even bigger and enroll into Medicare and get accredited, we do phase 3 Medicare enrollment with CMS, and then phase 4 comprehensive accreditation. Accrediting organization comes back a second time and spends 3 days with you and goes through a lot more comprehensive look of a lot more, not just your policy and procedures in your office setting, but they look at your personnel files or human resource and how you're prepared for that. They look at your organizational setup, similar to what they did in phase 1, but then they also look at the personal care component. That personal care piece is the most important. You have to, between phase 2 and 4, have taken on a couple of clients that are real life clients. They're famously go by pro bono patients.
It's not just a couple now.
Yeah.
It's more than a couple.
Yeah.
What's the exact number?
You need to have serviced 10.
Okay.
And then you need to have 7 that are active when the accrediting organization comes back. So truthfully, to keep that balance that we're talking about, sometimes it ends up being 20. Sometimes I've seen agencies or prospective providers that have done 40. So that's where you really should get guidance on how to navigate this process, which at Hess Consulting Group, we have created a course for our future clients that are going to take on phase 3 and 4 to teach them how to take on these pro bono patients. Because if you don't have the right guidance, you're in a rat race like this, because balancing them and just learning how the episodes, align, how to take on OASIS, so this comprehensive assessment for the skilled Medicare piece. It is there's a science to it. So basically 4 phases. If you're just looking to provide personalized services, non-skilled, you end at phase 2, you get licensed, you're on your way. If you want to get accredited, you take on more capital, financial responsibility, you take on more state as well as federal compliance regulation piece.
You provided us with an amazing amount of information already in the short time that we've been talking. And we were just going over the accreditation process for whether someone's going down the home care route or the home health route, and the nuance in each of those. And there's so many little intricacies. Like, for instance, you spoke about your experience as a nurse in the hospital, and as we are onboarding clients for phase 3, we're learning that the experience that our nursing team had from the hospital didn't necessarily translate into the proper procedure for charting and documentation for the clients in the home health agency. Can you just cover some of the differences in terminology and just, the approach to documentation for the home health agency versus what someone who doesn't have home health agency experience might utilize?
Yeah, that's a really good question, and it's a real thing in home health. When you're getting on trained as a clinician, as a nurse, straight off of nursing school or nursing programs, they'll tell you if it's not documented, it's not done. And so straight off of institutional and educational training, nurses think like this, that charting is volume, is really just covering everything that was done. And that's kind of like use acute care settings, hospitals, is volume. There is a shift when you are thinking in that perspective, and then you start building your nursing career and then get into like home health and the skilled documentation piece. There is a little shift there, because when you are charting for home health, and I'm speaking more for the skilled, because the non-skilled, the charting is basically, was there a shower? Yes, no. It could be a yes, no, objective style, and then a little subjective, free flow, kind of what they call a SOAP note. But when you're coming to the skilled world, you're not just charting everything that happened. Something could have fallen on the floor and you picked it up. We're not gonna chart that. Skilled documentation really should focus on why this patient is getting this service. Typically, you have a physician order that spells out the need for home health, spells out the discipline or which one of the clinicians is supposed to go see the patient, a diagnosis code that says why we're in there. There is physician certification for homebound status, or basically why this patient is being seen at home, Part A versus outpatient. So you have to chart to the specificity of these orders when you are charting for skilled home health. And that's a little different from the everything that happened must, everything that was done has to be charted. So when you're charting this in home health, there is a general comprehensive assessment that gets completed. And you talked about the unique things about home health. It's called an OASIS. An OASIS is completed at different time points. And those OASIS comparative assessments also, they do differ a little bit in how they're built, because CMS is collecting data from OASIS assessments And those OASIS assessments also have inbuilt with them HCPCS codes or billing capabilities that is a little different from hospital. Hospital, if there's a documentation review to justify service that was provided, is those notes or the documentation gets pulled up. But in home health, OASIS has dual function, not just what was done, but it also carries diagnosis codes. It also carries reimbursement codes that the encryption of that OASIS gets to spell out a certain amount of money that goes with it. And so we want to be as specific to the skilled need of that patient as much as possible, removing any additional redundancies, jargon that might not necessarily benefit why we're in this patient's home, and the services that we need to provide. Once you have that clarity in your documentation, it helps drive your care plan goals. When we create these care plans for skilled home health patients, they have to be individualized and unique to that patient's needs. And when you fine-tune your documentation, you'll come to realize it becomes a lot more seamless to follow through these goals of that care plan, and also allow us to be able to graduate these patients from the home health service. Typically, the skilled home health service is usually intermittent by design. It is designed to help patients that, as I mentioned before, are coming from an institution, hospital, rehab, LTACs, that are getting home, be able to adjust in their home environment, get to a prior level of function or a stable condition from, let's say, a surgery that they had, or if they had a sudden change in condition, such as like a heart attack or a stroke, and then they had to go into an acute setting, and then they went to rehab. So this skilled home health piece that we've been talking about all this while is really designed to help them transition back home. And then a long-term care service coverage, such as Medicaid, whether it's waivers or any other additional insurance, needs to pick up the long-term piece of our service. But Medicare is really designed as an intermittent service that comes in, helps you settle, kind of like you're going to rehab. You're just in an institutional setting. Mm-hmm. So documentation is everything to be able to paint the picture from if a patient's in the hospital, they're in the acute phase, and this is how the stabilization happened, and then they go into a SNF, or sometimes if they don't go to a rehab and they go straight home, how did we stabilize them at home, and how did that transition happen, and how can we graduate them so that they can get back to their prior level of function as fast as we can. So specificity to why we're providing this care to this patient or this client is very important, in just understanding that the home environment can bring a little bit more challenges, because you have caregivers, you have, neighbors, you have power of attorneys, you have a lot of people that are influencing.
A lot of cooks in the kitchen.
A lot of cooks in the kitchen. So very important clinicians to understand how to tie all those functions into why are you going in there, so that if you focus your charting there, your documentation, you can meet those goals, and then you can graduate those patients in the design and the fashion that it's intended for.
Yeah, and I know that shotgun approach to documentation is partly due in the hospital setting to the challenges that medical professionals face with the need for tort reform, because mm-hmm. there is tremendous insecurity for a lot of professionals mm-hmm. around, having their licenses under scrutiny mm-hmm. Because of, ambush chasers, right. But also because of the very real malpractice mm-hmm. landscape that we have here in the USA.
Yeah.
So to want to cover your
Totally
understandable. However, we do have a tremendous amount of waste in the hospital setting. And so changing the mentality of the approach to documentation for the home healthcare setting totally makes sense. And when you consider how, like, here in the state of Florida, they're moving towards a managed care model. I know that ACA has a lot of different managed care waivers programs, and they're moving a lot of consumers from APD, which is DCF's sister agency for the
run by the state.
Right. And so they're trying to move a lot of people onto managed care plans. And so considering how managed care was designed to try to eliminate waste, to try to mitigate financial losses, you know, it really does focus, in my opinion, more on the monetary element as opposed to the healthcare element of care. And so for operators of assisted living facilities, operators of group homes, you know, it sounds as if, you know, getting a home health care agency will give them the experience to be able to better negotiate and better prepare for the changing landscape that is not only here in the state of Florida, but nationwide, especially when you consider now we have a Republican-controlled legislature, executive and judicial branch. You know, Medicaid and Medicare have been top priorities for change. And so I'm curious what your thoughts are on how the assisted living and group home operator community can better position themselves with a home care agency in that changing environment.
You're bringing on a very important conversation in a very timely fashion as well. I'd like to advise our clients and our prospective providers as they're going through the licensure process, whether it's just getting licensed and then you have to credential into Medicaid, or if they're going for the accreditation and they're trying to get into Medicare. Medicare Advantage is here, and Medicare Advantage is not going anywhere anytime soon because, as you've mentioned, Medicare Advantages came on and they've grown tremendously along with the major changes that have happened in home health over the last decade that I have been in home health and learned everything that I have amidst all those changes. But they have been able to prove this methodology that you said in your opinion, that there's a cost-saving mechanism there. In Medicare Advantage terminologies, you know, really is not about the money, but it's about driving quality care. In that, if we pay attention and focus in the kind of care that we are providing, there's cost savings with that if we pay for quality. And so home health is going that direction. And I believe ALFs and group homes and a lot of different type of providers are going to end up going that direction. Medicare Advantage plans and are basically systems, healthcare systems that are putting the management piece of healthcare, not just in the government side, but in private insurance's hands. And so they have capitated type of payments where they're trying to say, instead of an hourly fee for a service, we're going to give you a bundle style. Here's a bundle, ALF provider, home care provider. If you do well with the quality metrics, you're going to make a lot more money if you manage this correctly. If you mismanage efficiencies, processes, your labor cost, and we talked about documenting for everything, sort of you're focusing on what you need to document for, then you're going to lose money. So they're creating all these incentives to say, if we pay attention to quality measures, we can save. So the drive behind that is quality, and we all have to adjust The only challenges, to your point you were saying, is that with the managed care organizations and entities at the driving force of care delivery, it moves sometimes the shift between what the patient really needs from the doctors and the clinicians that are actually caring for these people to whoever is in this financial organization that is controlling authorizations.
Yeah.
And so with Medicare, that decision of how much care was made by clinicians that are in the home along with the physician, really driven by the physician of these patients in the home. But with managed care, it depends on how much authorization was given. And I'm going to tell you for sure, it's not doctors and nurses that are working in those authorization departments. Yeah. So we all have an opportunity to share into these conversations and be able to advocate to where these right decisions are going to be made by people that are actually caring for these patients to be able to make these decisions. I'm not going to name any names, but some of the managed care organizations are sending nurse practitioners into the home. They're already doing all these things to justify care. And they're sending nurses, and there's that collaboration with authorizations. But there definitely needs to be more work done to ensure authorizations are run more seamlessly. And there's been a lot of backlash on some of these Medicare advantages and all these plans, managed care organizations, pretty much, in how they respond to and the timeliness of issuing authorizations, because patients transition from acute settings such as hospitals much faster than how providers in the community, home care agencies, home health agencies are getting these authorizations. And so the in-between, which is the providers that have, say, in home health, you have 48 hours to admit a patient. That's a law. If we don't get authorization on time, providers are left in the middle of the pickup. And so
they are not paying you for the time that you care.
And then they can refuse to retro.
Yes.
So we have to continue making noise. We have to continue advocating for better, more seamless, whether it's AI, whether it's new technologies that are coming out. Managed care organizations need to do better. They need to do better with authorizations ASAP. That should have been fixed yesterday.
Yeah.
And with the momentum and the saving costs models that they're showing improving that are working, well, some of those dollars that are being saved need to solve authorization problem. That's a big thing for home health and home care providers. And as consultants, we advocate for them. So that's a big one that they need to work.
And we have that same issue just in the group home space dealing with APD.
And as I said, who's left, in this issue is the patients and the clients. Mm-hmm. The patients are suffering. They're not getting access to care timely. So we have a moral obligation to really look at these models and make sure they're actually going to solve these problems and making sure that patients are getting the services that they need in a timely fashion, because their patients are suffering too.
Do you have an example of a state that does better than, say, what we're currently experiencing here in Florida with reimbursements?
I've clients in different states, and so I don't have an example at the top of my head, but I do know that there's a lot of states that are really trialing out, again, with the help of AI and all these technological algorithms to build systems where referrals are, they're getting at least somewhat of authorizations up front to cover that transition phase, so that the patient can come from the hospital and whether it's through a bridge referral program, the providers in the community are getting those referrals along with, maybe 3 covered visits, where, again, you and I talked about the case managers and discharge planners and coordinators can get basics as they used to back in the day, be able to get some sort of supplies and some sort of, when you're getting the supply setup completed for the patient to transition home for home health to pick up that piece, they should be able to get them basic authorization to cover, whether it's 3, whether it's the evaluation, whether it's the nurse, the first PT, or 2 of them that are going to happen. I know there's models out there, but I can't tell you exactly what state is doing them. But kudos to them, because I know that there's a lot of conversation around that.
So you mentioned being from South Florida.
Yes.
A lot of fraud in the state of Florida. A lot of fraud, especially in South Florida. 305, oh my gosh, they give us all a bad rap.
Right.
And we see countless large-scale providers get shut down for Medicare and Medicaid fraud.
Right.
We obviously want to stray away from any of that BS. Can you talk about the Medicare application process? Like when we started our group home, there were so many different moving parts that we had to go through, whether it was getting licensed with the agency, contacting the city, getting a change of use, seeing, how far apart from other operators our facility was, getting liability insurance, and on and on and on. There's just so many things. And then getting your Medicaid MPI number, you got to do things in tandem with one another. And so Medicare is a big piece that a lot of people have significant challenges with getting approval for. Can you just share some of that application process, how that plays into your timeline of your home health agency application process?
Right. So as I said, Health Consulting Group, we've simplified that process for you to a 4-phase process. Medicare enrollment is phase 3. For the state of Florida, once you've done phase 1 and 2, which is pretty much licensure, you've kind of collected half of those supporting documentation that we utilize to enroll in the Medicare. The unique thing about Medicare enrollment is usually a capitalization calculation that is usually either based on the anticipated volume of care that you're looking to provide or you're going to provide in 3 months and then again in 12 months of operations. That calculation is unique to the state, to the individuals, providers, prospective providers, and so that part is usually that's a little bit different. The other issue that prospective providers need to plan and prepare for. Something about the CMS review is that takes extended amount of time. And so typically when we file these enrollment electronically, we see a 45-day turnaround. But sometimes it can take longer. They do take longer because there is a background and fingerprinting process that has to happen from the moment you file that license application, and you have to coordinate with the agency owner for them to go out and get their fingerprints done. Well, one of the biggest challenges with CMS is they mail out these letters.
We just face that. The post office delivered to us.
And then a provider says, I always get mail at my address. So there's definitely room for improvement there where we advise on how they can get those fingerprints done. But this mailing out system is nobody can control but CMS. And then when you call, I hate to say it, but you're on the line for a long, long time, and providers such as yourselves are running other, business, service lines, and you're serving patients. And so there's not much time. And then sometimes you can task that to an administrative task support office manager that might not have the full information, or CMS might not even want to talk to them if they're not listed as a point of contact. So those are some of the challenges with Medicare enrollment that can really be frustrating for providers that are enrolling. But again, I hope that they get to hear some of these conversations from independent stakeholders like you and I that are in the industry, that we're doing the work, and they need to improve on that. Because on the online PICO system, once it's paid for and it's awaiting processing or it's under review, it's just sitting there. We need that system to be revamped so that we can see a little bit more, so we can, as we are holding hands with our providers that are enrolling, we can give them better information as far as, other than that. And I understand the safety functions and safety features, but knowing that consultants are out there, some of us are certified with the accrediting organizations, they need to think through how all these people are working towards making sure that these applications are filed, they're filed on time, and all the supporting documentation is received. The other one last thing for Medicare, there's certain forms that, that they're looking for, or the 588, like the financial institution information. But if you generate these applications, which we do, and try to filing them electronic so that they're not going by mail, because by mail is a whole 45, 90-day process just for it to get to their processing center, for it to be uploaded, and we want efficiency today, right? Is that when the reviewers actually send these back, they need to remember to send the electronic application back with it. Because what they'll do, they'll review it, send you a omissions letter, or like a corrections letter, pretty much, to what is missing or what needs to be corrected or updated, and then they won't return that application. Well, some of those, for instance, the authorized official certification statement, it's generated within their system. So again, that's something that leaves the providers in extended amount of time waiting. And I don't know how those workflows are, but if you're able to reach a reviewer, that you can get lucky and call in, and they do put their numbers there. Sometimes they answer, sometimes they don't answer. But if you're able to, they'll say, oh, I already worked that today. I'm going to get back tomorrow. And we're sitting there thinking, my goodness, what kind of systems are they working with? So I call out to CMS and to the government to help improve those efficiencies, because providers want to service people. And I think that you mentioned fraud at the beginning of this question. And home care and home health fraud has been around. And I think that's where you're seeing all the wave of the regulatory change, additional compliance, and really CMS trying to hone in and say, we need to focus a little bit on the administrative functions, focus on how patients are getting onboarded, focus. So they've reshifted, bringing on the PDGM models over around 2000 to kind of have home care and home health providers slow down a little bit on the fraud, because things were just flying, and the time crunch for clinicians to get documentation in, we understand that it's real. And because sometimes you have that large census and you have people that need to get seen, and then there's a driving factor. If you are building that community based clientele, you're going from one client to another. That's an advantage in an ALF. You're not going so far. Again, ALF advantage there. But basically, those are the challenges, and the fraud piece has been, all these mechanisms have been put into place that nobody in Southwest Florida anymore can go circumvent these things. So let me assure you, the compliance with the conditional participation is the same for the whole of the United States. Conditions for payment and those requirements are the same whether you're in Southwest Florida. And with a lot of the changes that CMS has made, I think, agencies have had to slow down. And hopefully there will be better situations in the next 5-10 years, definitely, with regard to that.
So we talked about a lot.
Right.
One thing we didn't talk about was I know we talked about your 13 years as a nurse.
Yes.
But we didn't talk about why you decided to leave the bedside and create your consulting agency. And I just wanted to ask because, starting a business is very challenging.
Right.
It's very difficult. Entrepreneurship is not for everybody.
Right. True.
And then your focus on the administrative element of not only starting one business, but multiple businesses for multiple clients.
Right.
That's typically the hardest part because a lot of people can do the work.
Right.
But, when they're working in their business, the administrative elements of the business can be very, very challenging. So how did you just come to choose, home health care as the consultant focus that you wanted to provide? And then how did you decide to begin your entrepreneurial journey as a mother with young children?
Yes.
Because a lot of people make a lot of excuses about why they can't, why they shouldn't, and they use those kids as
right.
the best version of themselves. And so it's very inspiring to see that you created your business to what it is today.
Yes. Thank you. I am a mom in chief, and I have 4 children, and I'm a twin mother as well. So I have sort of twins and all that. But my nursing journey, I was very fortunate. Straight from nursing, I kind of started in the hospital, which I always advise young nurses or nurses that, when I say young, but they're just coming off nursing school, to go into an acute care setting, because there you get your skills polished, right? You get to do a lot. And then as you grow as a clinician, as a nurse or a therapist, you get to build on that decision-making skill, which comes with time, prioritization, understanding what should you do first, what should you do second. That comes with time. So starting off somewhere where you can be your hands can be held, and these are very highly clinical environments in the hospital and well controlled, that's always a good place to start. From the hospital, I went to work for a SNF. So talk about this home care patient journey. I kind of did that with my career journey. So all of those pieces had come to make a lot more sense when I got to home health, because I had seen the patient from the hospital, took care of them. I work in a cardiac step-down unit. We did a step down from the ICU for open heart patients. We did stent placements, patients that had different cardiac procedures done. So I did a lot of that setting. Then I went to a SNF. They called it at that time transitional recovery unit, or it's basically rehab, right? Medicare rehab. So that patient, sometimes they go home with home health, or sometimes they go to rehab. I went to rehab with them. So I saw how they get received there. Learned a lot of the Medicare days, 21 days, and how all that gets handled. And I never had a desire to work home health because during my nursing school rotation with a community nurse, I had a really bad experience with the home health part. I had one of those bad home health nurses that didn't do much, but just arrange medication. So I didn't have a good orientation to home health as a nursing student. So I'd never had the desire to go that route. But while I was working at the SNF, or the Transitional Recovery Unit, I was approached from people that were impressed upon my character, my work ethic, that were starting a home health agency. And they thought, oh, you could make a good director. At the time, I had taken on a little bit more responsibility from just a staff nurse. I worked as like a manager or assistant AD1 level. And so they were impressed upon that, just meeting me in there, and had shared their card and started talking to me about starting this home health agency. And I said, I didn't know anything about it, but one of the fellow nurses that I worked with at that SNF or rehab said, you'd be perfect for this. Mm-hmm. And I said, the title is like a director of nursing, and I'm barely out of nursing school and just, getting my feet wet a couple of years in. And finally, after talking to my husband at the time, he said, what do you lose? Just it's something that you learn. And I had really bad experience. But I am faith-based, and I do thank God for opening up my heart to look into home health, because once you go home health, you don't go back. There's a known saying about that. Basically, I humbly started with this group of gentlemen that were starting a home health agency, and I started learning the business of healthcare in there. Because when you do home health, you don't just go to a patient's home to provide the care and go. You have to factor in supplies. I started thinking back about the hospital. Supplies all locked in a nice fancy room. You go in there, there's a lot of waste, as you mentioned earlier. But in home health, there's a coordination piece with supplies. You get to start seeing diagnosis codes. I never remember to see a code in the hospital.
Yeah.
Oh, so there's the code that drives care. There's supplies, and they have to be purchased, and you get to start seeing how much things actually cost. Oh, there's a labor cost to how much I'm getting paid, and versus how much do the administrative staff in the office getting paid. So your mind frame starts shifting a lot. You are privy to a little bit more of how those businesses or how those hospitals are running, other than just the clinical piece that the hospital had sheltered me, the rehab center had sheltered me to. Those were things that I never cared for. I just wanted to take care of patients. I went in, I took care of patients. I didn't learn that much. But here in home health, I started learning a lot of things. Oh, quality metrics, reporting. Oh, we knew we had surveys, but as a staff nurse, surveyor comes in, you still do the cares, you do what you do every day. They record, give you a report, but as I was doing home health, I was building a lot of my management, a lot of leadership. And those are skills that even if I was already a charge nurse working overnight sometimes, there were these forms and how things got set up was already pretty much done for me. Mm-hmm. That I have a tremendous appreciation for taking on home health for a decade, and how much I've learned about. I can walk into a hospital now and understand certain things that as a hospital nurse, I never paid attention to. Granted, I was a lot younger in my career, but I just knew I'd go there, took care of patients, did my charting, went home, and that cycle of things. So in home health, worked with these moms and pops, and like you said earlier, you wear all the hats, multiple hats when you're starting, but I got privy to how licensing, forms, quality, surveys, all these things. I left them and I said, whoa, I've learned so much from this agency. I'm going to try a little bit of a larger mid-sized company. So I went to a hospice agency, and as soon as I walked in there, one of the VPs said, we've been trying to start home health for a long time, and we cannot find somebody with your skill set. So I would like you to work home health instead. So there I got into another how to set up a home health agency environment for a mid-sized company. Progressed from there, and now I was really wearing the director of nursing or director of clinical services hat more comfortably. And now I had a career trajectory in home health that I was looking at. I was doing a lot of hybrid functions where I still went out to see patients, but I still did a lot of the office functions. Yeah. Came from there, and then I moved to Florida, and I worked for really large publicly traded home health agencies. Got some much wider experience as executive director or administrator level all the way to executive director. I worked regional that was also, as a regional director, setting up different branches and just understanding how the intricacies of those setups and how those work. And again, so I got to a point where I was able to collaborate with a group of other nurses to kind of participate in setting up an agency. And I felt a little bit sort of burnt out from just a lot of management, financial pieces, operational pieces, team management, that I said, I have all this information. How can I, now that once the twins arrived, and I'm looking for a little bit more flexibility, I thought, I definitely like teaching. I definitely enjoy working with providers and the relationship, the business aspect of things, as well as the clinical piece. So that's how I decided to start this consulting side of my career that I really enjoy, that we've been running 2 years now full time. In fact, I started the company in 2021, but I didn't know which direction I was going to go with it. I didn't know what we're going to do it, but we started 2 years ago, really honing in and studying the consulting side of things. Was able to get certified consulting training with CHAP and ACHC. Along the 10-year career, I was fortunate when the conditions of participation, the COPs changed in 2018. That law, that code doesn't change often. And so when it did, I had the opportunity of actually going to Cary, North Carolina, and training under ACHC. That's where the headquarters are. So I felt very well prepared to advise people, not just on the Medicare skilled piece, which I specialize in, but also the non-medical side, which is my passion because a lot of people start there. So when we're talking about reach, I want to empower as many providers successfully start, right? There's all these red tapes, there's all these requirements. We want them to start. We've positioned them to start well, and we have simplified the process. We're looking at all the needs that we're identifying. Taking on those pro bono patients is a lot. So we're creating solutions at HES Consulting Group to help anybody someday be able to say, I want to utilize the resources from this consulting company and be able to start my own. So that's a little bit about me.
Lastly,
my 13 years.
Tell us about the business, how people can reach you, what services you provide. So
services we provide is we consult to help you get your license. If you're an aspiring or prospective home care provider, you want to go from an individual provider, you want to tackle the list of things that you're supposed to have. We walk you through from how to get your business entity formed. So what should we have? You talked about getting your EIN, your tax ID, just your LLC or your incorporated, get your business set up, register with the Secretary of State. We advise you on that. And from there, we start going through what each state is looking for a provider to have ready. So we pull from those states, we're very familiar with those requirements, whether it's a liability insurance or an emergency preparedness plan that's comprehensive. We get all those documents ready with you. The with you model, I like to emphasize, is a passion of mine because there are consultants that are do everything for you. And providers fail when everything has been done for them, wrapped in a bow, and then surveyors are coming into their office to run survey for them. Policy and procedures have been provided for them, and they have no clue. So a do-it-for-you model was something that I said I will always keep. Hopefully in the future and things change of this company, but I want to be able to teach the provider so that at D-Day, they're not caught off guard and they're not surprised, because consultants can't take everything, fill it out, turn and burn. But I like to really keep the teaching aspect of what we do there, having conversations. So we have things like weekly progress meetings. When a client comes to us, they've engaged us, we have a contract in place and a deposit. in place, which is usually half of our costs, and we break it down for them again. We created those initiatives so that they're not paying large lump sums of money up front, which if you look at our competitors, that's what they're doing. They're collecting a lot up front. We are collecting, we're collecting a decent amount for us to be able to gauge your commitment, but we also want to allow these providers to be able to function on top of all the expenses that they are having to go through this process. So we've simplified some of those things, and we go through a weekly progress meeting with you scheduled at your time of convenience, so we can keep the conversation going, so that, as you know, as opposed to putting some consultants put you in a class for a week and go over 10,000 information, we've seen better results when owners and providers are going through this in a 1 hour, 2 hour fashion over 4 weeks, because things pop up next week and the third week and the fourth week, and they've looked at the supporting documentation list, and maybe this week they were too tired. So things happen when it's cramped up. So we've kind of spaced it out over a month period. We're holding your hand. We're working together to get these documents and giving you the education that you need. And then we go ahead and file it, and we follow it. So when the responses come, the owners get that information, they forward it to us, so we collaborate to resolving those issues as soon as possible, so that the licenses are coming out as soon as possible. We're really big on efficiencies, and we're looking to take on as many people that are ready and those that are not ready. We also do offer our time to just do free consultations as much as we can in a month, just to get the word out. We're doing things like this collaborative social media engagements with whether it's providers or community-based events. We've got a pretty hectic calendar event calendar this year, but we're very excited to be out there. As far as reaching us, we're Home Health Edge at Instagram. It's just Home Health Edge. Our phone number is 813-524-7176. For best results, you can send an email, info@homehealthedge.com. So perfect. Email, phone, social media, send us those messages, and we have a website, www.homehealthedge.com. We want to give home health providers the edge that they need to be successful.